if you don't know already, you're going to learn who Dr. Bonhoeffer and his symptomatic psychosis, who that was. Now, critical always is context, right? So psychosis, NOS, I'm not sure what actually the DSM-5 TR term is for this, but they're not otherwise specified. Is not really a diagnosis, right? So when you see somebody in your clinic who seems psychotic, at least, and I'm really talking to the MDs here, one of the things you bring to the table is this idea of making a diagnosis that includes making a differential diagnosis, trying to figure out, what would be a good working diagnosis, and then proceed with this knowledge. So if you see this here, you can guess this was a while ago, my two children. And if our household looked like this every single day, you should worry, right? Maybe we're a hyperthymic family, and it's always we're always in good spirits. On the other hand, obviously context, if this is one day of the year, it's probably going to be okay. And the famous German poet who actually wrote a lot about medicine, Goethe, said the gods have put diagnosis before treatment. And I really emphasize this a little bit. Sorry for those who are not physicians here in the room. This is really something that I believe we cannot relinquish. Also, we really have to fight for that this piece does not get lost. Because I say this, there was a time when people thought, well, diagnosis doesn't matter. So I'm one of those, and we can argue about this, but I'm in the camp that diagnosis actually does matter, specifically when it comes to whether what we see is due to and I'm going to use the term organic here for simplicity's sake, if it's due to an organic reason. And let's be very clear here. Just like, you got to know more. So just looking here, it just, if you look at the Harvard pile there, I want to point out there is actually a person sitting in the middle of this pile of bags. And just to show that the issue of homelessness is not just a US specific issue. On the left, you have people sleeping. This is in Frankfurt, Germany. And on the right, that's actually a major park in Paris, France, where people are camping. So we do have this issue of homelessness. And on the bottom here is actually in Atlanta. There's some people sleeping under the overpass. But quite often, I think people just assume, okay, homeless and a little bit out of it. Well, probably psychosis. Well, depending on, it's not a totally bad guess sometimes. But in one meta-analysis, it was really only a small minority of people. This is a major meta-analysis, by the way, a couple of years ago. 12% of people probably have schizophrenia as a diagnosis amongst the homeless population. Now, it's going to depend on circumstance and where exactly you count and look. But just as a rule of thumb, I think that's actually good to know. And about a third of people that you see have some other form of psychosis, including schizophrenia. Just a heads up. So what it means in a way is actually not just jumping to the conclusion just because somebody is homeless and seems a little bit impaired or out of it to assume that this is schizophrenia. Now, I said Bonhoeffer. Some of you may actually recognize the name from history, but the person that you most likely will know is actually Dietrich Bonhoeffer, who was the son of Karl Bonhoeffer. Dietrich Bonhoeffer is a very famous European German theologian who was killed by the Nazis. So he's really the face of resistance in the church in Europe in those days. If you go to Berlin, you will see a train station, the Karl Bonhoeffer Nervenklinik. Nervenklinik is a term for state hospital. So Karl Bonhoeffer was a very prominent psychiatrist in Germany at the time. And he is considered the father of organic psychiatry. And this is what he said in one of his really seminal texts. And I'm going to say it in English here. Sorry, in German, it actually sounds as stilted as it sounds in English. That's just how the way the languages work and the way they wrote in those days. Crude exogenous organic damage of the most varying kind can produce acute psychotic clinical pictures of a basally uniform kind. What is he saying? Remember, I showed you my kids. Just by looking at somebody, you're actually not going to know if this is psychiatric, or let's use the term, or organic. So that was one of the things. In a way, if you think about this, is so we take this for granted today, but it's basically this guy who introduced the idea of delirium. Okay, so this is really when we started to try to look, if somebody looks psychiatrically ill, is there a group of patients who actually has something treatable medical? So there's so much for Bonhoeffer. There's a different way of looking at this. I'm going to give you one from MGH here, who was a resident at MGH, Charles Krauthammer, died a few years ago. You may recognize him if you're interested in politics and read editorials in newspapers. He was a very prominent commentator on the conservative side, but I always liked reading him. Made a lot of sense what he wrote about. So he really shifted at some point from being in medicine to becoming a political commentator. So there's hope for all of us if we feel this is not working out for us being in medicine to do something else. But as a resident, he wrote a very a conceptually important paper where he pointed out that if you see mania, just like Bonhoeffer, if you see mania, don't assume it's manic depressive illness, that it's a psychiatric type of mania. And he called it, secondary mania. So the distinction between primary and secondary. And I want to go over the list here, just like with the psychosis, that's a big list. I'm gonna tell you one thing about this primary secondary distinction. I like it. I like it for two reasons. Number one, it is actually in ICD, so the competing classification system, competing to DSM. ICD actually is using this primary secondary distinction. And a lot of our medical colleagues, because they use it in their systems, they have, I think, an intuitive understanding what we mean by that. So I think it's not a bad term. It avoids a little bit using organic, which we really should not be using. And this really works very broadly. And you can put at the top here anything, any psychiatric symptom, actually. It doesn't have to be new psychotic symptoms, or it could be anxiety, it could be depression. Okay. And then I put here ICD-11, primary versus secondary. The idea that some of these presentations are going to be due to psychiatric illness, in our case, talking about psychosis, schizophrenia spectrum diseases, or other psychiatric illnesses, or secondary due to delirium, dementia. I kept here the secondary general medical condition. I think it has gotten more complicated in DSM-5-TR and substance induced. So these old organic etiologies. I want you to take away one thing from this graph, okay? And that is that I did really put no hierarchy into this. There are, if you look at textbooks, sometimes the delirium is kind of the first decision point in this decision decision tree. Meaning, or you look at somebody and you have to make sure it's not a delirium. While I certainly obviously don't disagree with this, the problem is that quite often it's not so obvious, and these things are not mutually exclusive. And you know this, if you treat people, in the CL service, for example, with dementia, a lot of them, which is actually a risk factor for delirium, a lot of them will have both. And I do think it makes a lot of sense to at least initially kind of just list everything. And another example would be the person comes from a group home with schizophrenia. Well, if you keep it not hierarchical, it's actually really helpful, because it forces people to think, well, could it be a delirium in this person from a group home, as opposed to, oh, it's schizophrenia, it's probably just a recurrence of illness or an illness exacerbation. So I really feel very strongly about not being too decisive about determining, what comes from which symptom comes from what, but keeping it initially at least somewhat open. You do have a fundamental problem when you approach this issue. Let's just stick with the idea somebody comes in with psychosis, age 25, looks typical. Okay, is it let's just typical for schizophrenia, prodrome and then the first episode of psychosis, a little bit of cannabis use. Yeah, most likely, you're actually going to be right. It's the most common problem in this age group is actually psychiatric illness like schizophrenia, and it is very typical. But you have problems, okay? You may have also atypical presentations, and atypical presentations could be atypical in many ways with regards to symptoms, but also with regards to onset, age of onset. And this is where where the busload problems, as I labeled it here after old mentor of mine used to, he didn't call it busloads, but he basically, let me explain what he meant by this. When we presented a case to him, when my CL fellowship at MGH, he would always ask, well, how many patients with this have you seen? And depending what it was, Smith-Lemli-Oepitz syndrome, the answer would be maybe one now or two, one in medical school, right? So he would say, in other words, you haven't seen, I'm quoting, so excuse my language, you haven't seen a shitload of them. And the point always was that, well, what's typical and atypical depends a little bit how much you have seen. So it becomes a little murky. So when people say, oh, I'm seeing this atypical case of psychosis, the person is 35 or 40, saying, well, that's actually not so atypical. If you see enough patients, this is totally consistent with the age of onset. It doesn't really help you that much. The other problem that you have is disease prevalence. What's common and what's uncommon. Common things you will have seen, but common things may be common in your setting, uncommon in others, and the other way around. So just because you think it's uncommon doesn't mean it cannot actually occur. Let's use sleeping sickness as an example, or malaria. People could actually be presenting with psychosis, but you have probably never really seen it here in the United States. So even that doesn't help you that much. And just conceptually, what this points out, that yes, you still have to go with what you know about what you practice and what you have seen, which is kind of this first box. But you cannot ignore the boxes 2, 3, and 4. And you have to accept the fact that if something presents in an atypical way and it is uncommon, it's going to be really hard for you to figure out. And more testing is not going to be the answer. Longitudinal follow-up is actually gonna be the answer to that. So just keep that fundamental problem in mind, and that applies to me as well. Even though I have over 30 years of experience, there are still things I worry about missing, because I'm very aware. The more you know, the more you realize what you don't know. I'm very aware that there are going to be presentations that I've never seen and will not recognize at the moment. So if there's a genetic syndrome that usually presents in childhood, and now this atypically presents, when the person is 25, man, I'm going to miss this one unless I have a somewhat systematic approach how to address this intrinsic fundamental problem of in the end of epistemology. What is knowledge, and how do we create knowledge? So sticking a little bit with kind of some Europeans here, the way you conceptually think about this problem and the workups that you want to be doing. Well, you can be obsessive like the philosopher Kant, who is from my father's hometown of Kaliningrad today in East Prussia, Russia today. That a misdiagnosis could be catastrophic. And I think that drives a lot of things that we worry about. Well, if I miss it, it's catastrophic. And it's very true. If there's a medical condition that is very treatable, you do not want to miss this. There are other reasons why you want to be a little bit on the obsessive side early on, because if you put somebody with schizophrenia in the chart, that diagnosis will never leave that patient. And for the rest of that patient's life, potentially nobody will look more closely because, oh, so-and-so, some people at Yale already diagnosed, the person with schizophrenia. From a conceptual research perspective, perhaps, the only way to actually expand what we know about what illnesses can present, even atypically with psychosis, we have to look more. So we have to expand the phenotype. And that applies, I think, the discussion we always have about how much genetic testing do we do? Are we there yet? And for 20 years, I've heard, oh, we're not there yet. So I'm curious to hear what, also how you approach this in your system. But the reality is, only a diagnosed genetic disease allows for genetic counseling. So if we don't look for genetic diseases, we're not going to be able to help families, perhaps, even if it doesn't really change management. This is always the big thing that the MBA types push on us. Well, it doesn't change management and the yield is so low. In academic settings, I would push back a little bit and say, well, the yield may not be that low from the phenotype expansion knowledge creation side, and also, for example, here clinically, actually on the genetic disease side. Now, Schopenhauer was the philosopher of pessimism, was a very realistic guy, by the way, so I disagree with this assessment. But in a way, as we are told, and it's correct, the more you test, the more false positive results you're going to have. And if something is unlikely, the Bayesian prior probabilities, man, it's just unlikely you're going to find something. It is more likely that you will have a false positive test and then a wild goose chase. It's not cost effective, the MBA argument. Insurance will not pay. That's a very practical piece sometimes. And then I think that is largely actually true. If it's some sort of progressive disease, it will eventually declare itself. What's the problem? The problem is that in the United States, we are a big country. So it's intrinsic, I think, a problem to big countries. With a fragmented healthcare system, there's no guarantee that one person will actually continue to follow this person over time. And I see this all the time, that people come to me after 5 or 10 years of illness, and even just getting discharge documentation from prior hospitalizations has become almost impossible, depending where they went. Slightly different angle on this is, and you can put yourselves in either one of those. Are you a skeptic or an enthusiast? Are you skeptical about the value of diagnosis? Should have a high diagnostic threshold. Neurology, for example, is really skeptical when it comes to us saying, oh, well, we think this is temporal lobe epilepsy. All of a sudden the bar is very high, the motorship has to be involved kind of thinking. And on the flip side a little bit, well, we don't really know. It doesn't sound typical, but then you're not going to do anything because you don't have a diagnosis. So that's a little bit therapeutic nihilism. On the other hand, there's the enthusiastic approach, and let's use neurology as an example here. They push somebody to us, say, oh, this is depression. And you are thinking, well, I don't know. So you at this moment are a skeptic. You have a high diagnostic threshold, right? And they want you to do something. You think, you know what? You really think this is all social determinants of health and not really an SSI responsive type of condition. So those enthusiasts tend to make more diagnoses. There's all of a sudden, everything ADHD and all kinds of anxiety disorders and get diagnosed. There's more pharmacological interventions, polypharmacy. And they're also early adopters when it comes to, a new antipsychotic just came out. I want to try it. I think Hachinsky, you may recognize the neurologist from the Hachinsky score, gets it right, though. Without therapeutic enthusiasm, there would be no innovation. And without skepticism, there would be no proof. And you always can kind of look where you fall. And it is interesting, if you look at your caseload, you realize with this patient, I'm a real skeptic. And with this patient, I'm a real enthusiast. So it's also patient specific. And you may want to wonder as a psychiatrist, self-reflection, why that is that this patient gets the stimulant and the other one doesn't. So having said all of this, if you just think about why do we even do a workup, right? We want to make a positive working diagnosis of schizophrenia. These are the clinical features that we have, and we have excluded some stuff. I do not like the term, it's a diagnosis of exclusion. You still look for certain markers of these psychiatric syndromes. You want to avoid clearly missing easily treatable medical conditions. Delirium is the most extreme case of this. I do think there are other very important aspects to this. You want to establish a medical baseline for planned treatment with antipsychotics, and you want to assure patients and families and yourself that the etiology is not medical or neurological. It makes it a lot easier for me when I talk with families if I can say, oh, we did everything. We even did an MRI, so it is not brain cancer. Okay. Now I'm still in my mind, I'm still thinking, well, we absolutely didn't do everything, and it still could be something that we didn't look for. But I think it is very helpful to be able, actually, in my mind, to say this to people, and just to push back also when people say it's not cost effective. There's no yield. Well, you know what? At some point, somebody's going to do an MRI, right? If somebody pushes hard enough, you may as well, do it at the beginning. And if you think conceptually, then you can I really encourage you to create this list for yourself. I'm sure you already have, perhaps even in your system, somebody sat down at some point and for order entry, and it's just a click box or something. But there is a clear overlap between first episode psychosis, FES, and delirium. And with first episode psychosis, it's kind of what I said here. You screen broadly, and then you exclude specifically those treatable conditions like TSH, B12, and folate. Ceruloplasmin used to include. I'm actually no longer so sure if that's really good way to use our resources. HIV, because it's obviously ought to be diagnosed and it's treatable, and syphilis. And then you include more tests as you suspect this is a delirium, but also for people that don't respond to your first treatment. So I put here test more as clinically indicated, including treatment-resistant schizophrenia. That's what the TRS stands for, okay? Always remember, epidemiology counts, both figuratively and concretely, right? They just count dead, not dead, disease, yes or no. But clearly where you practice, depends. So this will determine what kinds of presentations you will actually see. And since I worked in the HIV clinic, I actually added this here. The immune status clearly counts when you see people. I just want to say here, for those of you who look towards guidelines, a fairly recent, very comprehensive one was done by the German government in 2019. And their notable recommendation with regards to diagnosis is to actually include an MRI in first episode workup. So there's at least one guideline that clearly says this. It is interesting, though, because it's a first episode group. They also say under treatment, indeterminate duration of maintenance treatment after first episode of psychosis. They were unable to conclude based on the literature what they should recommend with regards to maintenance treatment after your first episode of psychosis. Okay. I already talked about neuroimaging, so you have my slides. Just so here are some articles, including a very recent one. And in the end, it does boil down a little bit to value judgments, because the same numbers, there's always going to be a small percentage of what's called clinically relevant findings. And the question always becomes, well, how clinically relevant is it? In this publication, for example, they included cysts in it. I mean, you will find, if you do enough workups, cysts. I have yet to see anyone where neurosurgery actually was willing to do anything about it. So it's a little bit, even when people say clinically relevant findings, do look at the supplemental materials and make some judgments yourself. Yes, there is cortical thinning, and yes, there may be some non-specific white matter abnormalities, but it's really hard, I think, often to be clear what that actually means. And just also to have it on one slide for you, in my lifetime, there was truly just one new of these newly discovered organic diseases that can cause first episode psychosis, and this is the synaptic autoantibodies, particularly actually the NMDA receptor antibodies. It is interesting that, when this became known, so obviously, people started to look in the emergency rooms and first episode presentations. And then there was great hope almost that this would explain actually a significant number of people with chronic schizophrenia. And that turns out to be is actually not really the case. Once you're diagnosed with chronic schizophrenia, whatever that means, in terms of the duration. It's actually very unlikely there's such an acute process like this. It doesn't mean that they actually at some point could not have played some role. That's how I think about it. The case that I kind of alluded to, young guy, 25, psychosis, college, a little bit of cannabis. Okay, the problem that you have also is, that's why I think you got to be somewhat agnostic with regard to etiology and just list everything. Okay, how much of the cannabis use actually is truly responsible for the psychosis? If you stop cannabis, if that person stopped cannabis use, would the psychosis go away? So the best study that I can think actually exists is where in Denmark they looked at long-term follow-up of people who are diagnosed with the substance-induced psychosis, and then 20 years later, who was actually diagnosed with a serious psychiatric disorder. And it's interesting that of those people who presented and were discharged initially with cannabis-induced psychosis, 50% of those people in follow-up were then diagnosed with schizophrenia. That just points really towards the etiologically very relevant role that cannabis probably plays in actually causing, at some level, again, it's a big word, causation, but at some level, triggering, the illness, as opposed to if they just stopped using, it would all go away. And we had kind of as we went through COVID, sorry to bring up COVID here, it's not over, right? We had this discussion, psychosis NOS in the setting of COVID. What is it? Is it delirium? Is it really something that is unrelated to delirium? And I think we're actually not often 100% sure. In most cases, it is probably a delirium, but maybe in some people, it actually did trigger the onset of lifelong schizophrenia. So let's pause here with one slide left here, my clinical pearls. Psychosis, despite of what I said to be agnostic, it is delirium until proven otherwise. So don't get me wrong, okay? You want to be sure, but you can usually very easily see this too. So if there's on the CL service, a 75-year-old person presents with psychosis, ortho calls you, the found on ortho consult, right? After a hip injury, man, this is not the first onset of schizophrenia. This is a delirium. On the other hand, I did include one article here that I wrote with the colleague from McLean, that so-called acute and transient psychotic disorders, so something really in the non-organic category that doesn't exist in ICD as a category. Brief psychotic disorders comes the closest. They can actually appear pretty organic. People can look really disorganized and thought disorder in a way that feels organic. I said avoid the unnecessary hierarchical thinking. Unfortunately, we actually lost the multi-axial system. I think that's actually a real loss, that we don't really think very hard about the various contributing factors. Be flexible, the skeptic enthusiast, as I said. Have a high index of suspicion for new etiologies. There may be new stuff that we don't know about. And in tertiary care centers, I think this is where you maybe have the opportunity to contribute to science in that way. And then do expand your search for etiologies if there's a poor response. So here's a list of some resources. You see, I still have the same bad haircut. I still have the same tie and everything, but I stopped wearing a tie since the pandemic. So I did, when I came to this country, I actually started working. When I started working, I worked in a state hospital. I never really left the state hospital. Okay, hope that made some sense, and I gave you some 20 minutes. Good, we can have a bit of a discussion.